Good afternoon, everyone. Thank you for joining us for today's ParentMap live event. Today we have Ask a Pediatrician, a COVID-19 update for families featuring Dr. Kronman with Seattle Children's Hospital. Dr. Kronman is an associate professor of pediatric infectious diseases at the University of Washington, and he cares for children with infectious diseases at Seattle Children's Hospital, where he is also the associate medical director of infection prevention. My name is Brenna McCown. I'm the events manager for ParentMap. For those of you not familiar with ParentMap, we publish a free print magazine, and we also publish several parenting books, as well as host live and now virtual events, including parenting webinars, as well as fun family-friendly activities. Before we begin, I just want to cover a few housekeeping items. Today's webinar is being recorded and may be republished for educational or marketing promotional reasons. We will send a link to the recording to everyone who registered today, so you can watch it again or share it with friends and family. And we invite you to ask your questions through the Q&A. We'll leave time at the end of the session to do a live Q&A with our speaker. Thank you to our partner today, Seattle Children's, and thank you to our sponsors, Leg Up, No More Under, Little School, Yellowwood Academy, and Morningside Academy. Without further ado, I will turn everything over to Dr. Kronman. Thank you.
Thanks, Brenna, and thanks so much for having me. Thanks to ParentMap. Let me start sharing my screen here. I have a few slides to go over with everybody. Here we go. So yes, I'm a pediatric infectious diseases specialist. So I did my pediatrics training for 3 years after medical school, and then 3 more years of infectious diseases training after that. And I've been at Children's since 2011. And I thought what we would do today is I would take the first 20 to 30 minutes to go over details about coronavirus, some of which I'm sure are old hat for you at this point, and some of which may be new. And hopefully I'll provide some information there that will begin to address some of the questions that you have, both the questions you currently have or the ones that we received ahead of time. But we'll leave about 30 minutes at the end, more or less, to try and address some questions live as well. And I saw that there's already a few in the Q&A session of Zoom, so that's great. Keep sending them there, and I'll try and get to those too through the course of the talk. So first, I don't have any financial disclosures to let you know about, nor any conflicts of interest to tell you about. But I do just want to mention I'm an infectious diseases expert. I'm not a psychologist or a psychiatrist. There may be questions that you have that really aren't in my wheelhouse in terms of giving you the best answer, but I will try and stay focused on my area of expertise. The other disclosure is just that this is changing so rapidly. And of course, I'm trying to provide the best, most up-to-date information for you here today, but information may be different tomorrow or a week from now or a month from now. And so certainly keep going back to trusted resources like the CDC website or the Washington Department of Health website or other local health jurisdictions to get your best, most up-to-date information. Okay, so let's dive in. So what is a coronavirus? This is a word we've all become too familiar with at this point. Coronaviruses have actually been around for hundreds of years, and they are enveloped viruses, meaning that they have what you see here in gray. Hopefully you can see my mouse pointer, a protein envelope around their RNA, which is the center of the virus and how it propagates itself. And one of the important things about the novel coronavirus SARS-CoV-2 is this red spike protein. We'll come back to that in a little while, but this is one of the hallmarks of this particular virus. So we've known there have been coronaviruses for quite a while. There are 4 common strains that cause the common cold that many of us may have already had in the past and not even know. But then in 2003, the severe acute respiratory syndrome virus, which is another coronavirus, first emerged. And it made about 8,000 people sick, mainly in Asia, and about 10% of those people who were infected with that virus died. In 2012, the Middle East respiratory syndrome virus, another new coronavirus, emerged. And at that time, about 2,500 people became sick, but the mortality rate was a lot higher, about 30%. And so we know that these new coronaviruses can certainly make people very sick. And as you know, in 2019, a new novel coronavirus emerged, which we've now called SARS-CoV-2. We use that name to refer to the virus itself. When someone is sick from that virus, they have coronavirus infectious disease, COVID-19. So if we want to be real persnickety, COVID refers to the illness itself. SARS-CoV-2 refers to the virus. So unlike SARS and MERS, SARS-CoV-2 has just taken off, as you know, in terms of causing disease. So this is a map from the New York Times from yesterday, identifying hotspots with frequent and increased activity in the United States. And we know that worldwide there have been over 20 million cases now and over about 750,000 deaths. Not quite that many yet, but coming up on that number. In the US, we've had about 5 million cases and about 160,000 deaths. So these are staggering numbers. And I'll just point out in Washington there, we still have areas with increasing activity and ongoing activity, somewhat in King County and Snohomish County, but also east of the Cascades as well. So Yakima County, for example. So what symptoms does coronavirus cause? And as you'll see throughout the talk here, I've incorporated some flyers from the CDC because I think these are wonderful and they're great resources for us all, and they're freely available online for you to look for. So coronavirus can cause a lot of upper respiratory symptoms. So fever, chills, headache, cough. That cough can progress to be shortness of breath or severe difficulty breathing, but it can cause more minor symptoms as well, like fatigue, muscle aches, loss of smell and taste is actually a hallmark of this infection, sore throat, congestion, diarrhea, vomiting. And problematically, in some people, it causes no symptoms. They're completely asymptomatic, yet we can identify the virus in samples from their nose. So what are a few key concepts to talk about with regard to coronavirus? The first is that we mainly think that it spreads by respiratory droplets. So when we talk about spread of an infection, we think about three main ways that it can spread. One is by contact. So you touch a thing and then touch yourself or your eye, your mouth. So that's spread by contact. Respiratory droplets are when someone coughs or sneezes or sings loudly. They create these small respiratory droplets that fall out of the air because they're heavy enough within usually about 6 feet from the person. Lastly, there's airborne spread, where someone can, again, cough or speak, and the particle is so small that it remains in the air and can travel larger distances than 6 feet and get to people further away. We mainly think that SARS-CoV-2, and I'll probably end up calling it COVID most of this talk, is mainly spread by respiratory droplets rather than the airborne route, but it's possible that it's spread by the airborne route as well. And so this is where that idea of trying to maintain 6 feet of distance really comes from. We know that it can remain on surfaces. So in a number of studies, researchers have swabbed different kinds of materials, whether they are cardboard or metals, plastics, and they can identify the virus after periods of time, up to even 24 to 48 hours, depending on the surface type. What we don't know is how transmissible that is. They didn't do the study to see whether they could grow the virus, meaning that the virus could actually infect another cell, or is it just the RNA of the virus that's identifiable, but that it's no longer living and no longer capable of creating infection. So we don't know that yet. This key concept about asymptomatic infection and both asymptomatic and pre-symptomatic spread. So with many infections, when we are ourselves sick, that's when we're most contagious to other people. There are certainly some infections, influenza being one, where we know that people can spread it about a day before their symptoms develop. So those people are pre-symptomatic, they don't feel anything yet, but they're about to go on to have symptoms. We know now that for COVID, people can spread the infection one person to the next while they are pre-symptomatic, meaning that in the next few days they'll go on to develop symptoms, even mild ones, but also when they're asymptomatic. And estimates vary from study to study, but it's about up to 20 or 25% of people who have the infection remain asymptomatic. But of course, those are hard studies to do because you have to test large groups of people, including people who would feel that they have no need for testing because they're asymptomatic. So hand washing, as with many infections, is key. And of course, this means either hand washing with soap and water or using an alcohol-based hand sanitizer. There was even just a report in the CDC Morbidity and Mortality Weekly Report in the last day or two about a number of people who ingested these alcohol-based hand sanitizers and became very ill from doing that. So use those on your hands. They're not for eating. And masking is key, and we'll come back to masking toward the end of my slides, but masking helps us contain our own secretions so that we don't spread them to others if we cough, for example, or are talking loudly. And then distance, as I was talking about at the beginning of the slide, is key. Trying to maintain that physical distance, also referred to as social distancing, of around 6 feet or more from other people, really helps us stay out of the area where the droplets that they may be coughing or spreading could fall. So what about children and coronavirus? This is also from the CDC. This was back in June, and they looked at laboratory confirmed cases from January until the end of May. And what I'll highlight for you here is that in the youngest age group, 0 to 9, only 1.5% of all of the cases that had occurred in the United States occurred in that age group, and another 3.7% in the age group of 10 to 19. So adding those together, it's a little more than 5% of all cases. But children make up about 22 or so % of the United States. And so it appears that children get this infection less often than adults do. I should actually just also point out at the far right-hand side of the screen, this is the number of cases per 100,000 people in the population. And so you can see that across children, it's somewhere between 50 to 100 cases per 100,000 children in the population. Whereas among adults, it's closer to 400 and even up to 900 in the oldest age group. This was a recent publication, again, from the CDC from last week. And this looked at the COVID-associated hospitalization, so children requiring going to the hospital. And as has been shown repeatedly over the last couple months, there have been racial disparities in terms of who is getting sick and who's getting hospitalized with this infection. So you can see that white non-Hispanic children in the darkest blue bar on the left of each of these groupings had the lowest rate of hospitalization, followed by Black non-Hispanic children, and then followed by Hispanic or Latino children. And these numbers here are, again, per 100,000 population. And so they showed that the overall rate of hospitalization for COVID among kids at around 8 per 100,000 was definitely far lower than the rates of hospitalization for adults at around 165 per 100,000. So adults are far more likely to get hospitalized than children are. However, when children did get hospitalized, they often were quite sick. It was about a third of these children who ended up needing to go to the intensive care unit. So multisystem inflammatory syndrome in children is an emerging phenomenon that we're just learning about. And it is so new that different groups still are creating different case definitions. So the CDC has a case definition, the World Health Organization, the WHO, and others have developed case definitions. But broadly, what this is prolonged fever, 5 days or more, and multiple different body systems being significantly impacted. So that includes breathing difficulties, cardiac problems is very common. Vomiting and diarrhea is quite common. Some children have rash, bleeding disorders, and other issues as well. And so in addition to those symptoms, they also have laboratory abnormalities that are frequently seen in these children. And we definitely are seeing these children in Washington, and you can see in this map from the CDC that they are being seen across the country. There was early speculation that it could be related to a different childhood disease called Kawasaki syndrome, which also comes with fever, rash, red eyes, and a number of other symptoms for which we don't know the cause yet. But it appears, at least for now, that it's distinct, that the children who have MIS-C tend to be a little bit older, whereas the children with Kawasaki syndrome tend to be a little bit younger in comparison. And so there were a few questions we received before this talk about the relationship between the two. And for now, we should think that they're probably unrelated. Children who've had Kawasaki syndrome in the past could unfortunately get COVID and could get MIS-C to the best of our knowledge at this point. So how do we move forward? I thought I would touch quickly on vaccines, on how do we think about the school year, how do we think about activities, gatherings, travel, and then we'll really open it up to your questions to see what we can try and answer. So coronavirus vaccine is on the front of just about everybody's mind. This is a table from a recent publication in JAMA, where they outlined 5 leading possible candidates for vaccines. And you'll see in the second column there where it says technology, these use different technologies. So a couple of them use messenger RNA, which would then be incorporated by the body. Messenger RNA is then translated into proteins. And so these messenger RNAs would be translated into, for the most part, the spike protein that we saw on that graphic of coronavirus at the beginning of the talk. And then the body's immune system would see that spike protein, would see it as foreign, and would develop an immune response. The 3rd, 4th, and 5th vaccine candidates listed here use other viral vectors to spread the vaccine throughout the body. And these viral vectors are essentially deficient viruses that can't themselves make us sick, but they are a vehicle for spreading the vaccine throughout the body so that our immune system can recognize it and respond to it. There are currently beginning to be some animal data suggesting immunogenicity, which means that when animals are given these vaccines, they make an immune response to the vaccine. But there are many, many questions and hurdles we have to overcome before we get to the point of having a vaccine in everybody's hands and throughout the world. First, we need to figure out which methodology works best. And these different methodologies would be different in terms of their scale up and production, because the way that one would make a messenger RNA vaccine is different from how one would make a viral vector vaccine, for example. And so we need to sort of figure out which horse is fastest before we put all of our resources into scaling that production up and spreading it to the world. We start in vaccine trials with small numbers of people in the trial. And so it really requires beginning to give the vaccine to large numbers of people to identify any rare safety events that occur with vaccines. And so we wouldn't begin to learn those until we really were giving the vaccine to many people. We don't yet know much about long-term protection. An ongoing question is, if someone gets COVID, can they get it again? And we'll come back to that. It appears for now that we believe at least you can only get it once. And that's sort of the underpinning of many vaccines, that if you can make an immune response that protects you from getting that infection again, that's a perfect candidate for a vaccine. Many of you will be familiar with the flu vaccine. So the flu itself mutates rather quickly. And so every year, based on the circulating strains of flu virus, because there's flu A, flu B, and different lineages, we have to get a new flu vaccine every year. We don't know yet whether that would be the case for COVID, but I think many of us are hoping that it won't be the case, that it really will be one vaccine to protect us for the long term. And then distribution. So even though there have been 20 million people who've had COVID so far, that has been documented, with 7.8 billion people on the planet, that means that 99.7% of all people have not had this infection yet. So we have a huge amount of vaccine to make, and we have to get it distributed everywhere. And there's a lot of issues with, would it require cold chain and being kept cold to get to where it needs to go? How do we get it to all parts of the world, rural parts of the world, and so on? So that's a huge hurdle to overcome as well. People have estimated that from the beginning of the global pandemic, it might be about 18 months to make a vaccine. That's very optimistic. I certainly hope that's the case, but that still puts us almost a year from now. So I think, at least for right now, thinking about this upcoming school year, we really should think that it's unlikely that there will be a large-scale production of a vaccine that would impact this upcoming school year. So speaking of school, many people have begun thinking about how do we reopen schools. The National Academies of Sciences, Engineering, and Medicine had an expert panel. The American Academy of Pediatrics also put out a statement talking about what we should be thinking about in terms of opening up schools. And it is a gross understatement to say that this is a complex decision. There are many, many factors here. And I'll touch on some of these in the coming slides, but factors from cost to equity to food insecurity, concerns about domestic abuse for children trapped at home, to mental health concerns, again, children trapped at home who have anxiety or other disorders, children who have special needs and special education needs. And so there isn't a one-size-fits-all solution to this problem, but we'll talk about some of the factors. But the National Academies of Sciences really encouraged prioritizing opening schools as much as possible, particularly for those youngest children, kindergarten through grade 5, and for those who have special educational needs. So over the next couple slides, I thought this might help some of you think about how to make some of these decisions. And we can think about factors for family, school, activity across the spectrum. And what I mean by that is that there might be some factors in your family that might be protective or sort of optimistic, in the sense of there might be, you might have healthy children. The family members at home might themselves be healthy, the parents, the other caregivers. The children might be of an age where they could wear a mask, where they might understand the importance of hand washing and be able to comply with hand washing. For some families, they may be able to work from home, but others can't. And for some families, they may have a good deal of childcare flexibility. But on the other end of the spectrum, in your family, you might have high-risk children. And you might yourself be high risk as a parent based on your own healthcare situation. Or your children might be too young to be able to comply with mask wearing or washing their hands. You might be unable to work from home, or you might not have flexibility in childcare. And so it's likely that no particular family would fall cleanly on one end of this spectrum or on the other. For example, you might have healthy 1- and 2-year-olds at home, and the caregivers, the parents, might themselves be quite healthy. But if they're 1 and 2, they can't really wash their hands or wear a mask. And if you have a 1- and 2-year-old at home, you really can't work easily from home, or your job might not allow you to work at home. And you may not have childcare flexibility. And so over the next couple slides on the left are factors that are in favor of being able to do the activity, being able to go to school, to travel, what have you. Factors on the right-hand side of the screen are factors that should give you pause in thinking about participating in those activities. So these are some family considerations to think about. What about school? Well, factors that will make it less likely for there to be spread of COVID in a school are if the class sizes are smaller. And again, there's no one size fits all, no perfect number here, but the idea is how can we physically place children into a classroom so that they're spread apart. There's some suggestion that even 3 feet in a classroom setting, if the children are masked, might be reasonable, though many people still are hoping for 6. In a school where everyone is asked to mask, that's protective. If the school is able to create physical distance, that's protective. If the school is well-resourced, and that means a lot of different things. So well-resourced in terms of its financial ability to purchase plexiglass screens for lunch counter workers, for example, or people at the check-in desk, to a resource to be able to upscale distance learning and online learning if needed. These are factors that will help with that school being able to have a good educational experience this coming year. Plans for screening and detection in cases. So if the school has folks get screened each day and attest to the fact that they're having no symptoms, if they're detecting cases, if they have a plan in place for what happens if there's a case within a classroom, those are factors that are protective for that school. On the other side, schools that need to have larger class sizes, that's more likely to create spread in that classroom. If they can't universally mask or they don't decide to universally mask, if they can't create that physical distancing. if they don't have the resources to create some of those barriers, or if they don't have the resources to really provide a lot of online education and it requires the children to be at school, that increases the likelihood of spread. And if they don't have a plan for screening or for what happens if cases occur in the school, those again make it a little bit more likely for spread in that school. Okay, what about your local environment? So I'm here in Seattle. Many of you are here from Washington, and looking at your local transmission rates. So in Washington, we've had about 63,000 cases total, and we're having about 800 new cases in Washington each day. And that's sort of a 5-day rolling average where they average the numbers for the last 5 days. But it's been beginning to trend down somewhat. So that's really encouraging. But seeing what's happening at the time when school starts will be really important. Having high testing availability in your community. So in an urban community with a lot of clinics and academic medical centers, there's often high testing capability and availability. In a rural area, there may be very limited availability, and the test itself might get sent out and you might not get results for 3 or 4 days. And so that makes it more likely that there would be spread if you don't have that testing availability. That's sort of rapid test turnaround. And then contact tracing. So if the Department of Health locally is doing contact tracing to say, okay, you developed the infection and who were you around, and trying to identify the people you were around and screen them, the more that the local health jurisdiction can do that, the better, generally speaking. On the other side, if there's more ongoing local transmission, there's more likely to be transmission in your activities in school and so on. If there's less testing availability and slow test turnaround, and if contact tracing is not being done, those again would facilitate more transmission locally. Okay, what about activity considerations? So if an activity is outdoors, then it's not a closed airspace, and it's actually a little bit easier for any respiratory droplets to be dispersed and not to be breathed in by someone else in the activity. If it's an activity that can be done while masking is universal, that will help prevent the spread of the infection. If there's a smaller number of people involved, if during the activity people are able to distance physically, that will help. So if it's a barbecue at a friend's house and everybody's able to sit far apart, then that's on the safer side. If the people participating in the activity are coming from fewer individual groups, then they've had fewer individual exposures. And again, it's less likely to create transmission in that setting. On the other end of the spectrum, indoor activities, yes, in a closed, small airspace, it's more likely to facilitate transmission of this virus. If masking isn't universal or can't be made universal, again, that facilitates transmission of the virus. The more people who are involved, the more likely that someone there might be sick, pre-symptomatic or asymptomatic, and be able to spread the virus. If people are unable to distance physically, either due to the nature of the activity, for example, or whatever you're doing, then again, that creates physical proximity and increased risk of spread. So, a game of tennis outdoors might have a different level of concern than, say, a game of pickup basketball where people are, right there, right next to one another. So thinking about the activity itself will be important. And again, people coming from more family groups as opposed to just coming from a couple family groups would increase the likelihood of spread. So here's a few questions from the Q&A we received ahead of time, and at least one of these is relevant for the Q&A we've had here. If the virus enters our home, are we all doomed to get infected? And so, again, we're learning about this, but so far it does not appear that that's the case. There have been a few studies that have been mainly prospective, where they identified people who came in symptomatic with COVID, and then they followed their household contacts, their spouses, their children. And between the studies that have been done, it was about 16 to 25% of the other people in the household ended up becoming infected. It was more common that it would be transmission from parent to other people or parent to children rather than children to parent. And a lot of that may have to do with what we were talking about earlier, just that adults are much more likely to get this infection in the first place. And if parents ended up self-quarantining within the house once they developed symptoms, they were more likely to avoid spreading it to other people. So even though it feels like, what's the point? I've become sick, but I'm, living at home with the rest of my family. If I'm able to separate myself out and, quarantine in a guest room, for example, that may decrease the spread within a family. So that's important information. So here was another question. I have a 4-year-old and I'm a 24/7 single parent working full-time, and I rely on preschool so I can work. I'm hiring a babysitter. What precautions would you recommend? And I feel for everyone in this situation. This is a very difficult situation. I think we can think through a number of the factors we just talked about on the last slide. So the babysitter you'd be hiring, is this an 18-year-old or a 70-year-old? Do they themselves have other risks that either would make them more likely to get sick if coronavirus were brought into the house and they became sick from it? Or are they engaging in other activities where they might be more likely to acquire it and then bring it home? So if they're participating in a big soccer league and playing soccer and around tons of other people, that might make them a little bit more risky to acquire it and bring it to the house. So are they able to adhere to the published guidance and recommendations from the health department, mask wearing, staying at home as much as possible, washing their hands, that kind of thing? Those are a few factors to consider. And obviously this is a very difficult situation. Economically, parents need to get out of the house to work depending on their job. But this brings up a lot of anxiety to bring someone else into the family. So can you get COVID twice? We touched on this. We think probably not. It's a little too early to say for certain. But certainly I'm hoping that this is a one-time infection that people can get. So should children diagnosed with asthma take greater precautions to avoid coronavirus? Are children with asthma more susceptible to worse outcomes if they come down with COVID-19? Again, these are data from the CDC, and they looked at children in 14 different states who were hospitalized for COVID. And I highlighted here that 13% of them had asthma. Compare that to the fact that it's about 8% of Americans have asthma to begin with. So that's not dramatically different. And in one other small study from New York City, it didn't appear that asthma itself was a risk factor for developing severe COVID. Obesity, on the other hand, was associated with developing severe COVID in that study. So, I think asthma probably does not make children especially likely either to get it or to get severely sick from it. But certainly they already have an underlying lung disease. And asthma is, again, a huge spectrum where some people might have very mild asthma and some people might have very severe asthma. So the answer probably does depend a little bit on the individual. Of course, people with other severe immune system deficits, so bone marrow transplants, organ transplants, chemotherapy, very low white blood cells due to chemotherapy, those kinds of things would be factors that we would consider to be risks for developing more severe infection or for shedding the virus for a longer period of time, because they might not be able to contain and kill the virus due to their own immune system's problems. So masks, because a lot of people have questions about masks. I think it's really key to highlight the reason we wear masks is not as much to protect ourselves, but rather to protect other people. Now, in this second row of this visual, you can sort of see this person's coughing and the virus is being trapped by the cloth of the mask. So there are some do's and don'ts. Do wash your hands before masking. If you're using a disposable mask, you don't want to use it longer than a day. And if it gets soiled or it's being repeatedly touched during the day, you might want to change it more often than that. Cloth masks do need to get washed generally every day, again, is the recommendation. Make sure you're covering your nose and mouth. And wear a mask or have a mask with you if you think you're going to be around people where you won't be able to create physical distancing from them. Really try not to touch the mask repeatedly until you're ready to take it off, because you're just touching the environment, touching the mask, and potentially contaminating the mask. It's really recommended not to use one of those masks with a one-way valve where you're breathing air out through that one-way valve, because then you're really not protecting other people anyway. It's not really serving much of a purpose. Of course, for those with severe immune compromise, there are kind of higher grade masks, like those called N95 masks. In the hospital, we get fit tested to ensure that it's actually got a good seal on our face to prevent us from breathing in certain particles. That's not available, in the community. That's not a thing that people routinely do. But you might feel better wearing an N95 mask. I don't know that we have data yet to say that that's more protective than a regular cloth face covering. But again, masks mainly are for us preventing spread from us to other people. Okay, I just wanted to highlight the CDC website. They have a tremendous number of good resources there and a search bar where you can identify the topic of your particular interest, whether it's travel with an infant, what about being around immune compromised family member, how do I use a mask, those kinds of things. And thank you to ParentMap again for having me here. And I've managed to leave about 20 minutes for Q&A, and I can see that there are a few questions there. So I'll stop at that point.
Thank you so much. This is all fantastic information. Tons of questions from our audience, so I won't take up any additional time. Can you clarify the differences between vaccinations for adults and children? Is the time frame kind of expected to be the same? And will children be vaccinated safely along with adults when it becomes available?
Yeah, so I would anticipate that the vaccine itself will be the same for adults and children. Often what happens in medicine is that any new medicine or vaccine is tested first in adults because they can consent to the process of being in the trial. And we establish both that the new medicine or the vaccine, in this case, works in those adults and begin to establish some information about safety. And then as we learn more, we extend that down to younger ages. Given the worldwide nature of this infection, my hope is that studies would enroll children early on. And so we would have good data on children early on to show, again, that the vaccine would work in them and that it would be safe in them. So I don't really anticipate there being many differences in the vaccine between adults and children. But that is one hiccup that often happens as vaccines are being developed.
Thank you. How about symptoms with children? Are symptoms any different? And also kind of tying in, there's questions about long-term effects of children that have had COVID.
Yeah, thank you. We'll do symptoms first and then long-term effects. So symptoms, children can get all of the same symptoms that adults can get. It appears that they don't tend to get as sick as adults do. So it's possible that we may have more minimally symptomatic infections in children than in adults. But the symptoms otherwise should really look very much the same. But by that, what I mean is that a runny nose and a headache and a fever, that certainly could be COVID. A loss of smell and a cough, that could be COVID. And so we're looking for many of the same symptoms in children as we are in adults. In terms of long-term effects, the MIS-C phenomenon we talked about, the Multisystem Inflammatory Syndrome in children, that appears to be a later phenomenon after having had the infection. The estimate is that it happens maybe around 3 weeks, a month after having had the infection. And that itself can make children incredibly sick and can impair their heart function, for example, and the effects of that phenomenon could certainly have long-term consequences. It doesn't happen often, so the rate has been small, fortunately, but that's one way in which this infection can have long-term consequences. Beyond that, though, it really is likely to be like many other common cold type viruses in the sense that when one has a common cold, it doesn't cause long-term effects for you generally once you get over it. And so for most children, we wouldn't think that this would cause any long-term consequences, with the one caveat being that MIS-C phenomenon.
Thank you. What about just dealing with kind of the inevitability that someone in a large family with parents working outside of the home will eventually come down with COVID? And how do you have everyone wear a mask immediately in the home without kind of invoking anxiety amongst the children? What's your recommendations?
Yeah, again, I think this goes back to some of those spectrums I was showing in the family and the activities. Um, it's hard to remain sane in these times and not feel like, there's this invisible virus out there that's going to get us all sooner or later. I think quarantining within the family at the onset of new symptoms is probably a key thing, because that really does appear to help protect other people in the family. Trying to adhere to good hand washing, mask wearing outside the house, limiting unnecessary activities outside the house as much as possible, maintaining physical distancing outside the house. Those things all will decrease the likelihood that someone in the family will get it and will bring it into the house. But beyond doing those things, there aren't too many other things we can do other than try and kind of keep our heads down and keep going with all of the physical distancing we're doing now, and working from home when we can, hand washing, masking, and so on. There's no easy solution to that problem yet, unfortunately.
Right. A number of questions around different specific activities. So what are your thoughts about swimming pools, playground equipment, and even small kind of group activities like basketball, sports, etc.?
Yeah. Again, for each of these, I might think about a couple of those factors. So how old are the kids participating? If it's going to be 4-year-olds at a playground, or let's even say 2-year-olds at a playground, sticking a lot of things in their mouth, that might be a little bit riskier. If it's going to be 12-year-olds, playing 2-on-2 basketball with just 2 kids from one family and 2 kids from another family, and they can wear cloth face coverings the whole time, that's maybe less risky. Is it an outdoor area or an indoor area? Is it a place where you could give it a quick wipe down before you start it? Or is it, too big and too crazy of a playground to think about doing that? Obviously, that might be unfeasible a lot of the time. Those are some of the factors that go into that. But I think, again, that decision will really have to be individualized for the family. One other layer to that just being, okay, so, my kids are going stir crazy. They've got to get out and do something active. But we also have, grandma who's 85, who's living here and who has severe lung disease. Boy, if she got it, she could get really sick. So that might limit your appetite for letting them go out. I think it really just depends on the situation of the given family, unfortunately.
Sure. Can you talk a little bit about any research on COVID and newborns or children under the age of 1?
Yeah. So we know that children can get it. Even in the first few weeks of life, there have been a number of reports of cases like that. It doesn't mean that they will necessarily get severely ill. Sometimes they may just have a fever for a few days, or cold symptoms without much else. There have been a few small studies of pregnant mothers who then deliver and who are positive with COVID, and they don't all pass on the virus to their children either. A lot of that, of course, has to do with all the routine things we're talking about. So good hand washing, masking, trying to, limit repeated contact while the mother is symptomatic in the case of an infected mother and a newborn. But that can, of course, be difficult with a newborn baby. So yes, we know that young infants can get the infection, and they can have a spectrum of illness from, very mild to, of course, there have been a few more severe cases, but those are quite rare at this point.
There's lots of questions regarding balancing children's mental and social and emotional health. And I know you have provided an excellent resource for weighing pros and cons and taking into consideration everyone's individual family situation. But if you could speak to just balancing those with also making the decisions of interactions a little bit more. I know there's a lot of questions around that.
Yeah, and I think we're all struggling with that. In fact, one of the reasons that the American Academy of Pediatrics, the National Academies of Sciences, encouraged school opening, there were many reasons that they encouraged school opening. So reasons from food insecurity and equity in our teaching systems to the ability of parents being able to work, to social and emotional learning, to the need for those youngest kids, kindergarten to fifth grade, to really develop those early skills in reading and language acquisition, knowing that they might fall dramatically behind if they're not able to really engage in that learning. So, I think we're all thinking about how to preserve the mental health, of course, of our children, of ourselves, because this is a marathon and not a sprint, as they say, because it's going to be a while before we have a vaccine. So I think what we can do as parents is try to control those variables that we can control, and we have to draw on our creativity to find those activities that will allow our children to play with their friends, to see their friends, to develop those healthy relationships. And so maybe it's, being in a bubble with your family and one other family with kids of similar ages and having a lot of activities with them. Maybe it's more Zoom, time for your children with their friends, as much as we would want to avoid more screen time for our kids. So, I think trying to pick items on that left-hand axis of those various spectrums, fewer people, more outdoors, more hand washing, more masking. Those are things that we can control, which maybe just gives us the illusion of control, but that would decrease the risk that our children would end up getting exposed and getting this infection and bringing it home. So I do think there are things we can do to try and give our children those opportunities, while minimizing risk as much as we can.
Thank you. There's a couple questions and curious your thoughts on, or any statistics on, whether if you can smell cigarette smoke from another person passing by, does that mean that there's potential to also pass along COVID if they were, say, infected?
Yeah, I saw that question as a question before the talk today. It's interesting. So, and that really gets at this idea of respiratory droplets versus those much smaller aerosol particles. Of course, I'm not an environmental toxicologist, I guess, but the small particles in smoke, like in wildfire smoke or in cigarette smoke, are much smaller, and they can drift in the air much larger distances. And so that's unlike those, what we believe the main way that COVID is spread, with these smaller respiratory droplets that fall out of the air within about 6 feet. And so being able to smell smoke from someone 30 feet away does not necessarily mean that you could also catch COVID from them. The type of particle in the air is much smaller, and so can hang in the air a much larger time.
Thank you. Can you talk a little bit about the idea of bubbling with one or two other families and your suggestions around that?
Yeah, I think it's a great idea. The benefits are the ability to have those social interactions for both for our children and for us as parents. I think it just requires a lot of transparency and honesty between the two families in terms of risk tolerance, and what activities you're engaging in outside of that bubble, who's in the two bubbles, and are there contacts within there who are at high risk of getting severe disease from COVID or not. And so trying to find a good match might take a little while, but if you're able to find a good match, then I think that's a great idea and a great way to try and have some of those social interactions while still remaining physically distant from a lot of other people, as much as possible.
Thank you. With young children, specifically preschool aged, we know that they're always getting runny noses and coming down with something. So do we run our child to get tested for COVID every time they have a runny nose, or how long do we wait?
Oh, it's such a good question. I think that's one we're all struggling with. On the side of testing more, the more we test, the more we're able to find it in the community, have people quarantine, do contact tracing, and really try and stop transmission in the community, as well as really know what's going on in the community. Of course, testing your toddler with a Q-tip up the nose every 2 days is not a pleasant experience for you or for them. I think the more we're able to test discrete illness episodes, the better. So, if your daughter has a cold today and still has a runny nose tomorrow and still the next day, I wouldn't test 3 days in a row, but I might test once. And then if they go a week and they're fine and they've totally returned to themselves, but then they develop a new cold, yeah, we probably should retest them at that point, because again, it's one way to think about it is as a public service benefit to try and not only protect the people in the family and not spread it to others in the family, but also to identify where we are with this infection locally and prevent from spreading it to people outside the family. So it may end up feeling like a lot of testing. And I know general pediatricians that I've been talking with in our Seattle Children's Care Network and community are struggling with this, knowing that respiratory viral season is coming. It's August now, it's summer, it's sunny and beautiful, but come October and beyond, we'll be seeing more of these circulating other respiratory viruses, and we'll certainly see a lot of children who have frequent runny noses. The average is about one cold a month in the school-age kids. And so it may end up meaning a lot of testing for them. And I know that local pediatricians are thinking about how should we strategize and what should our algorithm be in terms of, do we test for COVID first and then influenza and then other stuff if needed, or, in what order should we do this testing? And so that's more to come on that, I'm sure. And, just to say it explicitly, the influenza season doesn't usually start until late December around here in Washington. Of course, this year probably won't be typical in any way, and so that may be far off, but that's when it usually starts. And flu vaccine should be becoming available pretty soon, and so getting an annual flu shot is the other way that we can try and protect our kids and prevent from having those infections over the course of the fall and through the winter. So that's something we should all be doing.
Thank you. Can you speak to the relation of COVID and pregnant women, and especially pregnant women that may have toddlers that are in preschool or socially interactive with other children?
Yeah, again,
transmitting that to the parent.
Yeah, that's unfortunately a common scenario where toddlers are in preschool and they pick up everything, both literally stick it in their mouth, but then figuratively they pick up every virus and bring it home, and they can get the pregnant mothers at home sick. What we're still learning, of course, about pregnant mothers and COVID. There have been some case reports that they might have more severe illness if they become infected, that they can have earlier pregnancy loss as a complication of the infection. So those are certainly things to worry about. I think, if someone's already pregnant, there's, the best they can do is, of course, good hand washing and masking if they can, and trying to keep those contacts limited. For people who are debating whether now's the right time to get pregnant or not, I think it's so unpredictable right now what's going to be happening in the world and how long it might be to get a vaccine, that I don't know that it's easy to make a rational decision about that at this point. But I think, all of the routine things with masking and hand washing and physical distancing are, going to help try and prevent that transmission as much as possible. That feels like very much a non-answer to me, unfortunately, but I think that's just where we are.
Thank you. What would be your recommendations for things parents should consider with regards to returning to school? Like, what requirements should the schools be putting into place to make them safe for those that are returning in person?
Yeah, I think, again, physical distancing as much as possible there in the school, including physical barriers in places where it makes sense to do that, in the lunch line, in the check-in desk, that kind of thing. Having the school have a real plan in place for what they're going to do for sports and other activities that usually brings kids close together, outdoor time. If the school is able to have some of the classes more outdoors rather than indoors, that helps when that's possible. This is Seattle, of course, so that, it gets cold and rainy, and that doesn't make a lot of sense. Having a school plan for testing, contact tracing, those kinds of things, I think will also help a little bit. And then, you know, the factors about the specific child and family members and how much that child is at risk or high risk of severe disease with COVID and how much family members are as well. So I think those are a lot of the factors. But in general, if schools are able to put a lot of that in place, then all other things being equal, in-person education would be better. And of course, you know, universal masking for the children as well. I didn't say that, but those are the routine things to be thinking about.
How about masking? There's a lot of questions masking with toddlers in preschools, and should that be required in preschools? How do we gently keep them continue reminding them?
Yeah.
Yeah.
I think this draws on our patience and creativity for sure. So, you know, we shouldn't mask people where it's unsafe for them to be masked. If they have a severe breathing condition, if they could breathe it in and choke on it and not know about it. So, you know, there is a lower age limit beyond which we shouldn't be masking folks. I think in that 2 to 3 year old age range, it's possible to have the masks be fun, be, you know, characters from their favorite cartoon or a set of shark teeth or, you know, whatever it might be, that would get them engaged in doing it and trying to make it a habit and a game and, you know, positive reinforcement and, you know, continuing to be positive about the whole thing. And of course, demonstrating ourselves that we're wearing our masks are the best ways to do that. But it's, I empathize with those with the toddlers at home because that's a hard age to get them to do anything they don't want to do. And so I think if it's becoming a huge battle, it's not worth fighting that battle, but rather continuing to do it yourself and, you know, try and do good hand washing and make the best of it.
Thank you. Well, we're 1 minute away from our time for today's event. I wish we could keep going. There are so many fantastic questions, but you have provided a great outline of information and helpful tips on making these really challenging decisions as a parent. So thank you for sharing your expertise and everything with us. We appreciate you joining us today. And thank you everyone for joining our ParentMap Live event. Please feel free to check out parentmap.com/live for more parenting webinars and fun family activities. We have an event this Thursday on microschools and different options for returning or not returning back to school this fall in different ways. So thank you again to everyone joining us. And thank you, Dr. Kronman, for your time today. We appreciate it. And thank you to Seattle Children's as well.
Thank you for having me. This has been great.
All right. Bye, everyone.
Bye.